We'll start then. Again, thank you everyone for joining us, and I'll talk today about narrative fallacy in clinical psychology and psychiatry. Interrupt me at any time if you have any comments or questions, and we'll have Q&A at the end. I was hoping to clarify, because I'm getting a lot of feedback on the term narrative or on the word fallacy. The two words together is a specific technical term introduced by Nassim Taleb in 2007. My intention is not to have a broad discussion about narrative theory, which is vast with anthropology, linguistics, nor am I very set on sort of truth versus fallacy. I just wanted to point out something very specific, technical, if you wish, on the ground, under the hood, which I call narrative fallacy. But I do think that it has profound implications for clinical work, and I am looking forward to your comments very much. This is the link to the preprint. You can download and read it fully. Paper was published in 2023, APA Journal of Practice Innovations. And perhaps before we start, maybe we can experience a related phenomenon together before I define it formally. What I will ask you to do, if that's okay, is I will give you some words, and I'll ask you to try to memorize them. And please observe how you feel while doing so. Is that okay with everybody?
Yep.
Let me try. Okay, here we go. Magnolia, 1964, Chicago, Jazz Club, Winter, 10, firefighters. What I will do now is I will present to you the same exact words in a slightly different format, and I'll ask you again to observe how you feel while trying to retain the information. On a cold winter day in 1964, a jazz club, Magnolia, in Chicago caught on fire. The firefighters were on the scene within 10 minutes. To most individuals, the second format is slightly easier, and but I wanted for us to feel it together, that when the things are disjointed and we're just trying to hold on to these disjointed words, it's more effortful, there's more strain. But when they are in the story form, it is much easier. To move away from this artificial example, which I took from the RBANS, repeated battery for neuropsychological assessment, and modified slightly, a narrative fallacy addresses our limited ability to look at the sequences of facts without weaving an explanation onto them or forcing a logical link, an arrow of relationship upon them. Stated differently, narrative fallacy happens when we connect the dots into a story form, when we don't have sufficient data that the dots are indeed connected to each other, when we do it prematurely, if you wish. Stated it in even a third form, to quote Daniel Kahneman, we tend to think in stories in our extended consciousness, not probabilistically. This is an illustration from Professor Kiermaier, your chapter in this book, Crazy Like Us, where it's a fascinating story. Here is a advertising campaign by GlaxoSmithKline that consists of three major points: that depression is a common disease, it is caused by chemical imbalance, and the solution for that is Paxil. There are many things going on here. It's very compressed. There's 3 sentences, but I'm inviting you to consider that it's a coherent story where there's a problem defined, a statement about its etiology, and then a solution presented. And the only thing connecting these things together is something called monoamine theory of depression, and there's nothing else. In these conversations, we inevitably talk about Miller and his famous paper in 1956. Some people refer to it as Miller's Law. I think it's a model, but we see pretty robust evidence of that in neuropsychological evaluation, that on average, when we try to retain information in our minds, auditory information, we tend to fall off at around 7, plus or minus 2. Some people can do 9, some can do 5. And what he meant was not 7 digits, but 7 chunks of information. If by chance you are not familiar with that term, I'm in Maryland, and the area code here is 301, one of them. So 301 is just one unit of information, not 3 different ones. And therefore, when you chunk, you can retain a little bit more, but of these chunks, we can hold on to about 7. And even back then, we already knew that if we move from things like numbers or cards then to sentences, then the span doubles to about 15. I've already mentioned this term that is probably trivial to all of you, working memory. It's a construct and a model of a space and a function where we hold temporarily information while we are manipulating with components of that information while working on a complex task. Perhaps if I were to ask you to multiply 17 times 69 in your mind without a pen and paper, you will be using working memory. As the theory goes, that there's anatomical correlates, such as dorsolateral prefrontal cortex, perhaps the frontoparietal network, but you will use this function, this functional network called working memory. And one of the leading researchers in that field is Alan Baddeley. And he wisely points out that working memory is very tightly interrelated with long-term memory, semantics, perception, action. And it's pretty hard to do these diagrams with boxes and arrows because things are very interrelated. And if you like computer metaphors, then perhaps working memory can be compared to RAM, random access memory. And long-term memory storage in humans may be compared to a hard drive. Hard drives tend to be cheaper memory, more spacious. Working memory is more expensive and more costly, metabolically in humans. One of the famous models of long-term memory, the hard drive, if you wish, is by Squire in 1992, where we typically divide long-term memory systems into explicit, otherwise declarative memory, or implicit non-declarative memory. And again, these may be trivial terms to you, but I'll just highlight that by definition, explicit memory is something we can bring on into working memory. We can think about it. For example, an episode in your life, your 15th birthday, is an episodic memory, which is a subtype of explicit memory. Implicit memories, by definition, we cannot unfold or retrieve, if you wish, into working memory. A classical example is a motor memory, such as how the quad muscle on your right leg contracts and expands when you walk, is a memory. You've learned it, but you cannot think about it. So it's an implicit or procedural memory. And here is one of the models of the working memory. There are multiple components here. One of the earlier ones and well known is a phonological loop. This is, if you wish, a buffer where we process auditory information and speech. It's about 2 or 3 chunks of information. There's a visual and spatial sketchpad where we process visual data. Again, most sophisticated and metabolically costly component is called central executive. This is resource allocation, prioritization, and things of that nature. And the relatively newer component is called an episodic buffer. One of the reasons why it showed up is phonological loop is 2 or 3, while from Miller we know that we can retain about 7. So episodic buffer fills in that gap. The other thing that you can see here is that you can bind together things that are visual and auditory without the deployment of central executive system in the episodic buffer. And this is, related to the binding that I'll be talking about today. For instance, if you are thinking about colors, such as red and blue, and you're thinking about shapes, then there's nothing really connecting the two things. But if I were to tell you about a red square and you were to visualize it in your mind, then that's the binding. You perform the binding of a color and a shape together. As it relates to speech, the two kinds of binding simply refers to linking features into objects, such as the red square that I've mentioned. But the two terms that relate to narrative fallacy are within sentence binding and across sentence binding. There's a very interesting phenomena where we use what we know. We use the knowledge of language while we process incoming speech or when we read, and we do it relatively automatically and without much effort. Within sentence binding is how we process one sentence together, and we do a lot of things when we do that. And across sentence binding and how we bundle together multiple sentences into a paragraph or prose passage. Let me illustrate it with the example that I gave you earlier. On a cold winter day in 1964, a jazz club Magnolia in Chicago caught on fire. The firefighters were on the scene within 10 minutes. When you hear that or read it and you hear on a cold winter, you can predict that the next word will be day. And this is, if you wish, predictive coding in action. And what you're doing there is semantic prediction. By the knowledge of language, you know from context that the next word would be day. Similarly, within 10, you know that the word will be likely minutes. Then there is syntactic compression or syntactic predictions, if you wish. We expect in affirmative sentences in English a verb after a subject. So when you hear a jazz club magnolia, you are waiting for a subject, for a verb. And then we chunk. On a cold winter day becomes one chunk, jazz club magnolia within 10 minutes. So we do all of this machinery fairly automatically, and these are all components of within sentence binding that have to do with how we know language. We use our knowledge to do these things. So it's an interaction between long-term memory systems and working memory, and the episodic buffer is involved in that. And a cross-sentence binding is, again, in our example, there are two sentences. You can see that they're temporally related. Firefighters showed up after the fire. There's a reason they showed up, and they took care of the problem quickly. And we're able to do a cross-sentence binding here for two reasons. The story is coherent and it's meaningful. If we were to manipulate these variables and do something meaningless but syntactically correct, such as Chomsky example, colorless green ideas sleep furiously, not very easy to retain. Or if we maintain the meaning, but we fiddle with syntactic context, then it's also not very easy. Here is a quote from a poem, Utah, by Anne Stevenson. Beside him, the gray-headed man has let one arm slide awkwardly over his shoulder, is talking and pointing at whatever it is. So we need both coherence and meaning. And I'm quoting here the book by Thorne and Page, Interactions Between Short-Term and Long-Term Memory in Verbal Domain, where can we bind things that are unrelated, just like the words I gave you in the very beginning? Yes, we can, but it will be resource demanding. You will have to use your central executive for that. Again, these are formal definitions, and I've already mentioned that this can happen relatively automatically and that you will use the interaction from long-term memory, your knowledge, to do this. So babies cannot do that, and if the language is foreign to you, you won't be able to do it. But when you know enough, then you can. And this is a cross-sentence binding again. Now, the interesting pivot here is that we think of brain-mind as an efficient processing unit from multiple perspectives, from biological perspective, from free energy principle perspective. Kahneman may have called it lazy, which means that we default to the simplest possible processing regime, and we only deploy complex, effortful regimes when we have to, when the task requires us to do so. And we usually don't feel good when that is the case. So if, again, the Kahneman's example, you're doing 17 multiplied by 69 in your mind without a pen and paper. If you are in the car, actually, before you're in the car, if you put a video camera in front of your face, and it will probably show that your pupils dilate. But also, if you are in a car making a left turn onto oncoming traffic, then you could run into an accident because your working memory resources are depleted. And again, I don't know exactly why affect is negative, perhaps because it's dangerous to run on empty. But that's a speculation on my part. As a result, if we are doing something very sophisticated for a long time, then we need to consciously commit to using and being in this resource-intensive regime of processing for that extended period of time. Otherwise, we will regress or default to a simpler one. And then we run into this universal phenomenon of fatigue. Every single function in our minds gets tired. I'm a psychotherapist, and there are stories in, I think, New York Times of children of therapists. And on a Friday night, I'm not very pleasant, nor am I pleasant at lunchtime. So we have auditory fatigue, we have impulse inhibition fatigue, compassion fatigue, and all the other kinds of fatigue. What I'm trying to say is, regardless of the level of training and knowledge, we're all human beings, and we're all prone to narrative fallacy simply by virtue of being human beings. When we are unaware that this is the case, that we could be doing narrative fallacy, which means connect the dots prematurely, connect the dots before we have evidence that they're connected. If we have the lack of insight about that, then we will be more likely to do it. This is another pivot, and I'm quoting here Mark Solms, that how we think influences what we do in clinical practice. This seems like a very trivial statement, but to me it's important, and it has important implications. And as a simple example, it's basic knowledge. So if a psychotherapist is unaware that a thyroid dysfunction may actually present as if it's anxiety or depression, then they may not ask a patient this question: when was the last time they did thyroid blood work and with thyroid panel? And if you have neuropsychological knowledge, you can use it, but if you don't, then you won't. Personal psychotherapy matters a lot because it does change how we think and how we perceive things and how we react. Uh, certain skills matter, whether we can be flexible and we can switch to continuous type, thinking versus discrete thinking. Both may be appropriate for some circumstances. Are we able to think statistically at all in probabilities? Are we able to consider transience, emergence, and complexity, or we think in deterministic fashion? All of these things matter, and they will influence how we understand what's happening with a patient. And related to that, there's this concept of case formulation, widely used in psychotherapy. And there's a famous book by Nancy McWilliams, who is universally loved, I think, by therapists of all kinds. But formulates a hypothesis about the causes, precipitants, and maintaining influences of a person's psychological, interpersonal, and behavioral problems. And it is the primary tool of, hypothetically, but understanding what is going on with the patient. And it takes time. In graduate programs, I would say it takes years between sort of working with patients, supervision, knowledge, and it's a continuous refinement. And it's not an easy thing to master, and it's never complete learning. But it's not unique to therapy. I'll give you a concrete example from outpatient neurology, if you wish. It's anecdotal, but the joke is that competent neurologists can suspect Parkinson's before the patient walks in the door because they can hear shuffling. And when the patient does walk in, by the way, they usually walk in with an explanatory gap. They don't know what's happening. They want to know what's going on. So they walk in and the doctor heard shuffling. And then the doctor observes that there is flat affect, rigid posture, difficulty initiating movement, cognitive slowness, and perhaps a rolling pin tremor. Then the doctor may become more confident in the hypothesis of Parkinson's, and they may say so much: I think that you may have Parkinson's disorder or Parkinson's disease. That is a formulation. You have Parkinson's disease is a sentence. And as you can see, the explanatory gap here was filled by the knowledge of that these symptoms together, they mean something more. They are a syndrome called Parkinson's, and this is something the doctor learned. So the explanatory gap was filled up from the knowledge of neurology. But among other things, the case formulation typically, traditionally, is a story. What I think I will do next is I will give you this short case, and bear with me, it's not the real deal. It's much shorter than what we see on the intakes. And I will look at the same patient from multiple standpoints. Is audio okay? Can you hear me well?
Yeah,
Yeah.
it's good.
So, and you can practice, you can try to think your way, whatever school of training you have. You can be a CBT clinician, EMDR clinician, I don't care. Family systems is popular now. Try to make sense of what's happening with this patient. Mr. A 52-year-old married businessman, presents on his own initiative with a depressive syndrome after being once again passed over for promotion. He does not understand this rejection, but it is probably related to his lifelong tendencies to procrastinate and to annoy his superiors, either by being obsequious or by challenging their authority. He has a history of 2 untreated depressive syndromes, one in his 30s that also followed a professional failure, and one in his 40s that followed his son's defiant marriage to a woman of another religion. Mr. A's father was a sickly, professionally frustrated, quote-unquote type A personality who died of a heart attack when Mr. A was in his teens. His mother has always been a martyr, with smoldering despair characterized by chronic insomnia, self-doubt, obsessive ruminations, and social withdrawal. She never sought treatment. Mr. A has essential hypertension, for which he takes metildopa, 250 milligrams. His mother's history suggests a genetic predisposition for a unipolar depression. Let's imagine this is all you know. And our job is to try to make sense of this and say, what's going on here? What's the main mental pain for the patient? How did it come about, right? So now, for the sake of example, let's imagine that you are a clinician trained in a tradition called ego psychology, which is the first form of psychoanalysis going back to Sigmund Freud, elaborated by Anna Freud in the States, Charles Brenner and others. And the highlight thing here in the ego psych formulation would be a mental conflict. I think Freud used a lot of military metaphors. But here it goes. Mr. A's central conflict is between an unconscious wish to kill off his competitors and an unconscious fear that he will be killed if he acts on that wish. Whenever he expresses derivatives of his competitive wish directly, he becomes frightened of retaliation. He therefore resorts to expressing the wish indirectly by passive-aggressive maneuvers such as procrastination. Conversely, whenever he responds to this fear of retaliation by being solicitous and obedient, he inwardly feels resentful and diminished. To contain this struggle, Mr. A has developed intellectual mechanisms that, although adaptive for certain aspects of his work, are maladaptive interpersonally, and that they isolate him emotionally from others. So mental conflict was the core of the formulation. Now, let's imagine that you are a Kohutian, you are a trainee in the School of Psychoanalysis, going back to Heinz Kohut from Chicago. And the central part here will be narcissistic vulnerabilities, self-objects, failure to idealize your parents, and narcissistic rage and things like that. Mr. A's central problem consists of his low self-esteem and consequent need for continual recognition and approval from others, along with his inability to accept any limitations either in himself, which lead to disapproval from others, or in others, which reduce the value of their approval when it occurs. Presumably, during childhood, his depressed mother and sickly father were so self-absorbed with their problems that they were unable to respond empathically to his age-appropriate aspirations. At the same time, both parents narcissistically invested in their son the hopes that his achievements would make up for their failures. Same patient, different school of training, different way to understand what's going on with the patient. Here's a third one, object relations school, going back to Melanie Klein. Here you'll hear about splitting, projection, projective identification, failure, and integration. Mr. A's central problem is his failure to integrate the good and the bad representations of himself and others. During childhood, his depressed mother could not respond to her son's need and demands. Mr. A is unconsciously frightened that his resultant rage would destroy the very one on whom he depended. He repressed his bad, angry self and acted like the good, obedient son. The splitting was reinforced by interactions with the controlling father, who punitively viewed any of Mr. A's independent assertions as acts of defiance. This is a third version of the formulation. Now, something to reflect on is the following questions. Are these formulations short and tentative, you think, or they're elaborated and detailed? And how certain do you think the author of each narrative was? Again, purely artificial cases I'm trying to illustrate to make a point. Here's a CBT example, different patient, but also depression. And its authoritative source called Essential Components of CBT for Depression by Persons. I suggested to Nancy that I spend a few minutes in the session giving her a first notion about how CBT would address her difficulties to help her decide whether she wanted to pursue it. She agreed. To teach the cognitive model, I mapped onto a thought record the situation Nancy had described to me earlier when her roommate Connie looked hurt when Nancy turned down Connie's invitation to go out to dinner. I asked Nancy a short series of Socratic questions to show her how these thoughts made her feel guilty, inadequate, and trapped, and how they could lead to behaviors of agreeing to do things with Connie that she did not want to do. So in this formulation, you see that thoughts are primary, and the pattern of thoughts, and this is rather cognitive, I would say, than behavioral therapy, are leading to the symptom onset. I've already used this example, and it is grossly oversimplified, and psychiatrists now are very much more sophisticated, but still SSRIs are prescribed, and the diagnosis of MDD, major depressive disorder, is given. And when the physician thinks that the patient has, this is how it's usually said, I have MDD, and the SSRI is prescribed, let's say 10 milligrams of Lexapro, then that's a formulation of a chemical imbalance. And what connects A and B here is something called monoamine theory of depression, which doesn't hold water anymore and probably belongs in a museum. But that's the only thing that holds these two things together. And treatment is administered this way. The medication is prescribed based on that cognitive glue of monoamine theory of depression, nothing else. We do not know anything about the patient's serotonin when this is being prescribed, right? I wonder if I should give this more detailed psychiatric example. Professor Kiermaier, what do you think? It's 2 pages. I'm wondering if I tired everybody with auditory fatigue. Should I summarize it, or should we spend 5 minutes with this example?
No, I think it's good to give the example. Having concrete examples will make our discussion richer, I think. So please.
Thank you, sir. Okay, so this is outpatient psychiatry, adolescent work. A 17-year-old girl was referred for her first psychiatric evaluation after 8 months of unsuccessful treatment for pain of unclear origin. The immediate reason for referral was the patient's worsening symptoms of depression and new onset of visual hallucinations. These symptoms had developed gradually after febrile illness, presumed to be viral, that presented with vomiting and diarrhea. However, her vomiting failed to resolve after the infection cleared, and it had led to a 25-pound weight loss. No medical cause had been found for the intractable vomiting. Relevant prior history included additional gastrointestinal difficulties. She had had multiple diagnostic procedures, which were ultimately inconclusive. In the initial interview, the patient did not express any distress about her persistent vomiting, although she did report feeling of overwhelming depression and being scared by, quote, visions of people in my room. Her mother, whose primary concern was her persistent vomiting, brought a calendar and a diary to the interview that contained detailed documentation of her daughter's vomiting. It was not learned until the 6th visit that the patient's vomiting had started insidiously approximately 6 months before the presumed viral infection. Around that time, she had a major conflict with her biological father and decided to stop contact with him. She also had a history of academic underperformance. A school psychologist's evaluation performed before the onset of her medical problems did not qualify her for special education. The patient's mother decided at that time to homeschool her to improve her academic performance. Initially, they were part of study groups with other homeschool children. Because of the patient's multiple medical problems, low energy, and inability to get out of bed on most days, however, the mother withdrew her from the groups. The patient's social interaction with peers her age has been limited to a weekly youth group at church. She reported that she has never been able to have a friendship lasting more than a month. So I'll just read to you, and this example is from Winters, Hansen, and Stoyanova, the case formulation in child and adolescent psychiatry. So this is what I'm moving on to their thoughts about what's going on. There seemed to be a significant enmeshment and ambivalence in the mother-daughter relationship. The patient uses somatization as a way to express her feelings. Although her visions are clearly distressing, they have a phobic rather than psychotic quality. She was offered the option of an antipsychotic medication and later reported relief of her fear, but continued to have the visions. As you can see, that these 2 paragraphs are much more loaded, and they seem to be a bit further away from the data. And first of all, there's a little bit of blame the mom going on in the first sentence, which was popular in the 60s. But then there's an interesting term. The patient uses somatization as a way to express her feelings. And that's a very old theory, and perhaps psychoanalytic originally theory, that there's a mental distress of some kind, and it manifests as a physical symptom, perhaps as diarrhea. And, originally was thought to be a form of psychological defense. But this is how this physician, this doctor, thought of what's going on here. And then there's another thing here. A response to medication is considered here as data. And I'll talk about that a little bit later. Now, what I'm inviting you to observe in all of these cases that I presented is that, we can look at these hypotheses, so to speak, and ask a question from the standpoint of Karl Popper. Are they falsifiable? An example of a falsifiable statement in science is the following from physics. The water boils under normal pressure at 100 degrees centigrade. It takes one experiment to prove it wrong. If you observe it under normal pressure boiling at 90, you're done. You falsify the hypothesis. I'm stating that none of the things you heard today are falsifiable. So you can't disprove them if you wanted to. So how are you testing them? The second thing is a very important thing that unfortunately I didn't know about when I was in grad school. It's the Forer-Barnum effect, and people who do psych testing run into that quite a bit. What Forer did in 1949 is he gave his students a personality questionnaire, which they dutifully answered, and then he mailed them the results. And it was about 50 students, I think. Each one got identical page, and they did not know that. But he took a page from an astrology book and mailed them all that text. Then he asked them to rank how accurate they thought the description was of their own personality, 1 to 5. Anyone in the audience wants to guess what was the average? 4.5. So his students thought that the description was very accurate. And what this effect means is that when we feel resonance with a certain description or a certain text, that doesn't mean one bit that this text is accurate. And astrologists milk this effect like there's no tomorrow. This is their livelihood. And I ran into that when I was doing psych testing. The patient would say, well, doctor, this is magic. How do you know this about me? And I said, whoa, hold on. Be critical. Let's examine this. But this goosebumps, this awe, this resonance is a very interesting effect. And we run into that in the clinical work. And effort justification bias. I'm stating that perhaps it took a bit of work to come up with these formulations and training and supervision. And if we put work into formulating a hypothesis, we would be less likely to let go of them and entertain other ones. So I'm summarizing that sadly, we don't have rigorous, independently verifiable framework of hypothesis testing in psychodynamic or any other kind of psychotherapy, and I think in psychiatry as well. We think we do. We claim that we are hypothetically deductive, but I don't think that's actually the case. Please forgive a little bit of mathematics, but if you look at the same thing from the standpoint of active inference / free energy principle, where we are minimizing the variational free energy, it can be decomposed into complexity minus accuracy. This is another way of saying that all other things being equal, when we think, when we make conclusions, when we try to make sense of stuff, the way brain works is complexity is minimized. And this is another way of presenting the Occam's razor principle, where among different explanations, we will gravitate toward a simpler one, usually by default. So to summarize, the problem is that when we're driven by theory, more so by the data, and when we have formulations that contain conclusions upon conclusions based merely on assumptions, then we seem to be deeply entrenched in our theory and not in the data. And at the end of the day, what else do we have to fill in the gap? Neurologists had their training and we have ours, and this is how we make sense of the explanatory gaps. So if we acknowledge this phenomenon, can try to stay more data-driven than theory-driven, which is not easy in the medical practice. You routinely hear these things that the patient tried this medication and there was no effect. Related to Professor Kiermaier's work, there's this construct of treatment-resistant depression, very popular now, especially with Spravato and ketamine treatments. But what it means is that the patient had no response to 2 courses of SSRIs. And then it's deemed that the depression is resistant, and therefore Spravato or ECT or something else. Well, but who says that they should respond to SSRIs? Just because somebody, in the genius of marketing called SSRI an antidepressant doesn't mean that it's supposed to work. So this is a tricky one in medicine. And we can consider that a lot of these inferences and hypotheses should be probabilistic, and they should have probabilities attached to them and not just a story, which usually means 100% probability. And if we're rigidly adherent to one school, some people identify this way. They walk around saying, I am an EMDR clinician. I am an IFS guy. And then we see referrals like that. I'm looking for an IFS guy. I'm looking for a Kleinian. I'm looking for this or that. And I think that this will increase the probability of narrative fallacy versus decrease it. We should have thoroughness. We should deeply study each of these frameworks, but then we should be able to zoom out and stay meta to them. And certainly, I think that the awareness of narrative fallacy and Barnum effect helps us rein it back in and be tentative and questioning our preliminary hypothesis. You may wonder if sort of may there be an example with minimized narrative fallacy, and this is a bit artificial. In reality, we have much more data coming at us. But let's imagine that the patient reports to you that they suffer from disturbing intrusive memories that are visual images, let's say an image of a Glock handgun. And these images are concrete, timeless, and intense. When that happens, they are sort of re-experiencing that. And let's say that you have collected enough data to suspect acute PTSD with adult onset, single traumatic exposure. Then we can tentatively conceptualize what's going on here as a flashback. And then you can use that information to, to guide further treatment. Now, let's also assume that the patient had no PTSD symptoms before the exposure to the traumatic event, hyperarousal, avoidance, hypervigilance, that intrusive memories are consistent with the content of the trauma, where the image of a gun happened as a flashback, but the patient was robbed at gunpoint. And then we can use the knowledge of flashbacks. So I think that this is an adequate, information collection process here. Bear with me, I threw a lot of words at you, so let me show you a picture. And I want to thank Olivia for her gorgeous flyer, but this is, maybe a homage to her. Did you see the video?
Yeah.
So there were only a few seconds, but I'm inviting you to consider that when you looked at it in motion, then you had a lot of information coming your way. And what you're looking at now of this static frame, perhaps you can get information about the rocks in the waterfall and maybe something else like trees, but you have no idea about the turbulences and the speed of the flow and none of that. Because this here, the photograph, is a cross-sectional time slice, while what you saw before is a dynamic process with complexity, non-linearity, and a lot of other things. And here's another video that many of you have seen. This is a zebrafish brain. Let's just give it a few seconds. All right, so you can see, and this is a very simple brain, but what we work with is 86 billion neurons and in a very complex, network configurations that have different regimes from coma to, hyperarousal. But how do we formulate, say the MDD, we say things like the patient has major depressive disorder, perhaps comorbid with generalized anxiety disorder. And if you're doing a psychoanalytic formulation, then you will use different terms in different buckets, but you may say something like the level of functioning of the patient is borderline, their character style is obsessive, their characteristic defenses are isolation of affect, rationalization, intellectualization. But again, this is sort of, maybe a few more buckets, but buckets nonetheless. And you will run into that with neuropsychoanalytic formulations and with CBT formulations and with medical ones. So we are putting water flows in buckets. We are using deterministic tools, which is words, to describe something that is flows. And, to some degree, it is warranted in some circumstances. What we're doing here is we're coarse graining the dynamic phenomenon, and we hear from the patient. We are not in EEG looking at their brain dynamics. So we already have deterministic audio-verbal flow coming at us. But then we make sense of it also in audio-verbal fashion. And then these are our conclusions that are very compressed and very static and deterministic. So this is another way of doing the same thing, which is a common practice in nonlinear dynamical systems. What you see here is a landscape of attractors and repellers. Attractor is a stable point in phase space, like a ditch in the ground. And if you put a ball on the edge of the ditch, it's going to reliably fall down. Things tend to go there and stay there in a stable fashion. Perhaps if I were to tell you that the certain patient gravitates towards shame and on every session they feel embarrassed, then you could metaphorically say that shame is an attractor. And if they have a really hard time with anger and, they just, it looks like anger is amputated, then you could say that anger is a repeller. It is highly unstable part of their attractor network. And the whole thing moves. It's a river. It's not a static picture. Perhaps in therapy, it moves at certain time scale, but it also moves daily. So this is a very different way of conceptualizing the same thing. And there are only a small percentage of psychologists and psychiatrists who do that. But this allows you to consider the nonlinear dynamics, and then the depression is a phenomenon that is nonlinear, and it has transience, emergence, and contextuality, and it's not a label, I have MDD. So I think what we need to deal with this is to develop dynamic models which account for these things, contextuality, emergence, and transience. And we have theoretical frameworks for that. We have free energy principle / active inference. We have Michael Levin's TAME, technological approach to mind everywhere, nonlinear dynamical systems. The next bullet is a little controversial, but I know colleagues who do that, such as ISTDP clinicians. I know Beatrice Beebe in New York, who is studying mother-infant dyad. But neurologists, when they look at the MRI, they look at a static picture. But when they have EEG data, this is dynamics with temporal dynamics. And if we use something like video cameras or something else, then we include dynamical tools in our information collection. Certainly the awareness of the limitations of our methods that we use to understand what's going on with the patient, and avoidance of rigid adherence to one orthodox theoretical framework. And we don't have to go very far. If you read the update, the latest book by McWilliams called Psychoanalytic Supervision, what she does now is this 10, she calls them vital signs, but if you wish, they are 10 dimensions. Each of them is continuous. I'm not going to read them to you, but if you translate that method, and then the patient is somewhere on this diagram, and then things change. But essentially, in terms of physics, that means a 10-dimensional phase space. And what's happening with the patient, the dynamics will be the trajectory in the 10-dimensional phase space. But we can actually think about the patients functioning this way. We don't have to put patients in buckets. As a moment of levity, when I presented this work to different colleagues, I usually get little pushback from psychiatrists and little pushback from CBT colleagues. But I am a dynamic clinician, actually, but my colleagues who are full psychoanalysts told me, some of them are in agreement, but some say that I painted a straw man, that psychoanalysis is nothing like this, and that I'm not a full analyst, which is a little bit of a homonym version of that. Is I should read more Freud or Klein. Some people say that it's art and not science, and some people flat out say I don't work this way. And I even heard I don't formulate cases. And I find it hard to understand how is it that in clinical practice we don't formulate cases, we don't try to make sense and think what's going on with the patient. So I do think that these are all defensive reactions, while it's just difficult for us to say, look, we're human. Yes, it's a wonderful school psychoanalysis or CBT or anything, but everybody's prone to this effect. And we run into that effect when we're content with telling stories about what's happening with the patient. And I am done.